A very good evening to everyone. I am Dr. Sudeep Singh and I am currently working as the Director and Head of Nephrology and Renal Transplantation at Narayana Super Speciality Hospital, Gurugram. Today, we'll be talking about one of the commonest diseases in nephrology, that is CKD, what we call as chronic kidney disease. Understanding the pathophysiology, the causes, the diagnosis, and most importantly, how to manage this disease in day-to-day life. So this is a nephrologist's perspective to treatment evaluation of chronic kidney disease. So CKD, as we all know, is known as chronic kidney disease, basically means a permanent, progressive, irreversible deterioration in renal function over a period of few months to few years. So by definition, any change or alteration or deterioration in the structure or function of the kidney, which lasts for a period of more than 3 months, is diagnosed as CKD. What do I mean with that? If there are any abnormalities, for example, in the urine, we have hematuria, or the person is having pus in urine like pyuria or proteinuria, or there is a derangement of renal function, whereas there is a rise in urea or creatinine, or there is electrolyte abnormalities, and or there are problems that we diagnose on imaging of the kidney. For example, there is some structural alteration. We find a mass in the kidney. We find a decrease in the size of the kidney. So any abnormality that we see or we see in terms of lab parameters or in terms of imaging studies or along with the signs and symptoms, which I'll be discussing a little later, is known as chronic kidney disease. And as I have mentioned, it is permanent, progressive, and irreversible. So once the disease has started, it will slowly but surely progress to its endpoint, that is renal failure or end-stage renal disease, where as in the individual will ultimately end up on dialysis or kidney transplant. The rate of progression of the disease depends upon various comorbidities, various and the other factors, the clinical condition of the patient, at what stage he or she is diagnosed. And from there on in, it is the job of a nephrologist to delay the progression as much as possible. The prevalence of this disease is rising, and to the tune of it is around 10 to 11% worldwide, while some studies in India have also revealed that its presence has gone up to 15%. So one can say that 10 to 15% of individuals right now living amongst us are having this disease. And what is the most important thing? That this disease is a silent killer. Now, why do I say this is a silent killer? Because the early signs and symptoms of this disease are very difficult to diagnose. Why? Because they are often confused with non-specific alternative pathologies. So they present with minimal signs and symptoms, and the individual more often than not ignores the signs and symptoms. And it is because of this that the disease is not diagnosed. And once you reach the advanced stage of the disease or the end stage of the disease, then the symptoms come to the fore in a gross manner, in a magnified manner. And it is at this stage that people present to hospitals and to a nephrologist. So it is very sad that when a person actually presents, he or she only has 15 to 30% of his kidney function that is left. And it is a very or an extremely difficult job from a nephrologist's perspective to now delay the progression of renal failure and to delay dialysis or kidney transplant. Thus, it is also known as a silent killer. So this phenomena, whereas in majority of the population which are in the early stage of the disease or even the early moderate stage of the disease are hidden from all of us, is what we known as the tip of the iceberg phenomena, because it is only 10% of the people who actually present to us and who know that they have kidney disease. If we are to screen a majority of the people, then we'll come to know the actual prevalence of the disease which is there in the general population. So like, as we all know, the analogy which comes to mind is that the Titanic sank. It was an unsinkable ship in the early 1900s, and it had been made by saying that, it won't sink at all. However, it sank because it only saw the tip of the iceberg, whereas the majority, the 90% of the iceberg was under the water, and the ship ultimately ended up crashing in it and then sinking. Similarly, it is only 10% of the individuals who are actually coming to fore with CKD, and that also at an advanced stage. The early or moderate stage of the disease is in the majority of the population is remaining undiagnosed, and it is thus our job to diagnose and catch this disease early and shift the patient to a nephrologist's care at the earliest, so that the time of progression taken for the disease to go from the early stage to the end stage actually is maximized. So when we divide chronic kidney disease, it is divided into 5 different stages. The first stage is CKD1, which where the eGFR of the person is greater than 90 ml per minute per meter square, and he or she has other urinary abnormalities, which I've already discussed. Stage 2, which has a GFR of 60 to 89 ml per minute per meter square. Then stage 3A and stage 3B. 3A would be a GFR between 45 to 59 ml per minute per meter square, while a GFR of 30 to 44 would be CKD stage 3B. CKD stage 4 would be 15 to 29 ml per minute per meter square. And the final and the last stage of chronic kidney disease would be an estimated GFR of less than 15 ml per minute per meter square. Whereas in the patient presents with frank uremic signs and symptoms, which I'll be discussing henceforth. And it is at this stage that we ask the patient to either consider dialysis or kidney transplant as a definitive diagnose, as a treatment modality. So coming to the various causes of chronic kidney disease, there are a wide variety of causes of chronic kidney disease, the most commonly being diabetes mellitus, which is the most common cause of CKD, not only in India, but also worldwide. So controlling diabetes is the prime way of actually preventing kidney damage and further progressing of this disease. So like diabetes is progressing as a non-communicable epidemic, so is chronic kidney disease. And we will have at least 20 times the number of people that are suffering from chronic kidney disease secondary to diabetes in the next decade, at the end of the next decade. So other than that, hypertension is also an extremely common cause of the disease, and uncontrolled hypertension for a prolonged period of time can lead to kidney damage and can lead to chronic kidney disease and can actually worsen the disease in a very rapid fashion. So this is a vicious cycle. Hypertension leads to chronic kidney disease, and as the disease progresses, the patient develops worsening or resistant hypertension. Apart from that, there are certain idiopathic causes, for example, chronic glomerulonephritis, chronic tubulointerstitial nephritis, which also account for 30 to 40% of the cases of chronic kidney disease. And then we have various genetic causes like cystic kidney disease, which are inherited from parents, which could be autosomal dominant or autosomal recessive. They could be part of a more generalized or a wide variety syndrome, for example, Alport syndrome, where it also affects the other organs of the body, for example, the genital organs of the body. And apart from this, people who have recurrent urinary tract infections or have problems of kidney stones, they also develop chronic tubulointerstitial disease or chronic kidney disease. Apart from this, if you are on long-term painkillers or you take certain alternative medications which have Chinese herbal or metallic compounds, this can also lead to worsening of kidney function and ultimately progressing to chronic kidney disease. So these are the causes of chronic kidney disease. And now the question arises, what are the symptoms? And as I said, that the early stages have minimal symptoms. So we need to know about and be aware of the symptoms of chronic kidney disease. And once we know the symptoms of chronic kidney disease, then we can diagnose it early, and then we can start the treatment early, and we can delay the progression of the disease. So commonly presenting symptoms of this disease would be swelling around the eyes, what we call as a periorbital puffiness, and then swelling around the ankle, which is often pitting in nature, what we call as a pitting edema. That is, if you put pressure with your thumb on the shin of the tibia, you will find a pit forming there. And why does this happen? When the kidney function actually worsens, there is salt and water retention in the body that leads to accumulation of fluid, especially in the dependent portions or positions of the body. Early stages of kidney disease in CKD would present with increased frequency of urination, especially during the night. So if one is waking up multiple times at night, then he or she should get his kidney function evaluated. Apart from that, a change in the color of urine, when you have blood coming in the urine or you have frothiness in the urine, which actually indicates that there is a lot of protein leakage, or there could be pus in the urine, which could be sign of infections, and chronic infections can also progress and lead to chronic kidney disease. So any change in the color of urine, the consistency of urine, the frequency of urine, and even the odor of urine. The foul smelling urine in advanced stages of chronic kidney disease, you have a very foul smelling odor, which emanates not only from the urine, but also from the body of the patient, which we call as a uremic odor. So change in color, consistency, or frequency all indicates that this could be a progression of CKD. In final or end stages of chronic kidney disease, there is a decrease in the urine output, and the patient goes into oliguria or decreased urine output, especially in end stages. So that is also a sign of chronic kidney disease and denotes its progression to the end stage. Apart from that, presence of abdominal pain in the lower part of the umbilicus or below that, which is the suprapubic area, or in the bilateral loins or at the back behind the ribs where the situation of the kidney is, could denote presence of urinary infections or kidney stones, which can further progress if not treated to chronic kidney diseases. Apart from that, the patient can also progress in this disease and present with symptoms like low hemoglobin or what we call as anemia, which happens either iron deficiency, blood losses, or suppression of the bone marrow, which is unable to produce RBCs, and there is a lack of erythropoietin in the body, because of which the hemoglobin falls. As erythropoietin is synthesized in the kidney, kidney damage would lead to low erythropoietin levels, which in turn would lead to anemia or low hemoglobin. And along with this, high blood pressure. So as the disease progresses, the patient often presents with uncontrolled blood pressures or high blood pressures, which require even more drugs to actually control hypertension. So this is another common symptom which presents with this disease. As the disease progresses, the patient can present with frank uremic symptoms. And when I say frank uremic symptoms, they could be like nausea, vomiting, altered sensorium, where the person goes into encephalopathy, seizures, accumulation of fluid in the lungs, which we also known as pulmonary edema, and nausea and vomiting, especially which has blood in it. So these are all very serious complications of chronic kidney disease. Apart from this, the person can have a dry, itchy skin. And again, in advanced stages, if he is not treated, the patient can also present with uremic udder, which is extremely foul smelling, and severe pruritus, which presents as itch marks on the skin of the person. So now going from the various signs and symptoms of chronic kidney disease to diagnosis. So how do we actually diagnose this disease? This disease can be diagnosed by various investigations, which include blood investigations, which are the most commonly used investigation. The single most important predictor of progression and diagnosis of chronic kidney disease is kidney function test. And this can be actually includes blood urea, creatinine, and creatinine is how we monitor the disease also. Apart from this, we have to get serum electrolytes done to know as the disease progresses, the patient might have high potassium, hyperkalemia, or even low sodium. Apart from that, get the CBC of the patient done, because low hemoglobin is again another hallmark as the disease progresses. Apart from that, there is a derangement of large number of metabolic parameters. For example, uric acid, whereas the person presents with hyperuricemia or high uric acid, and low calcium levels, hypocalcemia, high phosphorus levels, hyperphosphatemia, vitamin D deficiency, and hyperparathyroidism. So all these metabolic derangements have to be looked for, and all these parameters have to be tested. Apart from this, urinary examination, which includes a urine routine microscopy to look for presence of pus or blood or even protein in urine, and to quantify the exact amount of urine leaking through by a spot urine protein creatinine ratio is extremely important. Apart from that, to rule out UTI, we require urine culture sensitivity. And we require imaging tests of the kidney. When I mean imaging tests, I mean ultrasound to look for kidney size, to look for the presence of cysts in the kidney, to look for the presence of enlargement of the kidney in cases of infections, to look for any hydronephrosis which can happen in strictures, or obstructive nephropathy. Obstruction itself is also can be a reason for chronic kidney disease if it is long standing and not corrected. And apart from that, sometimes in certain cases, we require a CT scan to further go and see the anatomy or the structure of the kidney in further detail, to look for any small stones and so on. So related to these conditions, we get other tests done. If we consider genetic causes of CKD, we go for genetic markers. If we consider for autoimmune causes or other tumors which are leading to kidney disease, we go for those investigations. And thus, along with the clinical signs and symptoms, blood investigations, urine investigations, and imaging investigations help us to diagnose chronic kidney disease. Now, coming to the most important part, that how do we treat these diseases? Well, these diseases have to be referred to a nephrologist as early as possible. Once the creatinine goes above 1, you have to immediately refer to a nephrologist who will evaluate the case, see in what depth the kidney disease has progressed to. If there is any doubt of the diagnosis of kidney disease, or there is large amount of protein leakage in the form of nephrotic syndrome, or along with protein leakage, RBC leakage, and there is pyuria with normal sized kidneys, we go for the gold standard diagnostic test for evaluation of kidney disease, that is ultrasound guided kidney biopsy, with the help of which we actually know whether how much of the damage is acute and how much is chronic and long-standing, and what are the causes of this kidney disease. So first of all, refer the patient to the nephrologist early. Once the patient is under the nephrologist's care, the investigations have to be done as early as possible. And once they are done, then the nephrologist decides in what frequency the follow-up should be. So early stages require once in 6 or 3 monthly follow-up. And once you reach the end-stage kidney disease, every monthly follow-up is required. Control the primary cause of chronic kidney disease. So one has to control diabetes by controlling the blood sugars and being in close follow-up of an endocrinologist. If the hypertension is the reason, control the blood pressure and use 1, 2, 3 or multiple combination of drugs and keep the blood pressure under the correct limit of 120/80. If you are having high weight, control the weight and bring your BMI under 24, which is very important because metabolic syndrome and obesity also contributes to chronic kidney disease. And lower the cholesterol levels, because even dyslipidemia can cause cholesterol deposition in the renal arteries and can worsen ischemic nephropathy. So you have to control all these parameters and the causes of kidney disease. So once the patient has entered chronic kidney disease, avoid intake of any alternative medication, Chinese, herbal, or any metallic medication which the person might be taking or seeking the help to, and which is the religious and cultural beliefs of lots of other people. Avoid over-the-counter painkillers and do not start any drug without actually connecting with your nephrologist. Diet is extremely important. One has to take in the different stages of chronic kidney disease, a salt-restricted diet. Potassium has to be restricted because it is a tendency in chronic kidney disease, especially when the disease actually goes on advancing, that there is potassium retention with hyperkalemia, and this can lead to various adverse cardiac consequences as well. And sodium and water retention can lead to fluid overload. So a salt-restricted and a potassium-restricted diet. Fluid should be given according to the output of the patient. So amount of urine produced by the patient and whether he or she has any signs of fluid or volume overload. In advanced stages, there is restriction of input of fluids, and in end stage, it is usually 1 to 1.25 liters in 24 hours in patients who have oligoinuria or no urine output. Apart from that, protein restriction has to be there to 0.7 to 0.8 gram per kg body weight, depending upon which stage of chronic kidney disease one is. That is from stage 3 to stage 5. And once the person is dialysis dependent, whether he is on hemodialysis or peritoneal dialysis, the protein intake has to be increased, because dialysis also results in removal of good substances like the proteins from the body. So they have to be replenished, because muscle mass and nourishment is very important. Malnutrition will obviously increase the propensity of infections and mortality in patients of chronic kidney disease. Apart from that, one has to get all the metabolic parameters investigated, and wherever there is a deficiency or excess, you have to treat it. So for example, for high phosphorus, you give phosphate binders. For low calcium, you add calcium containing compounds. Then you have to treat anemia by adding injectable erythropoietin and giving multivitamins, or subjecting intravenous iron therapy if the patient is severely iron deficient or B12 deficient. Then if there is very severe anemia, then one might have to transfuse blood as well. For high uric acid, we use anti-hyperuricemic agents. For high cholesterol, we use this anti-hypolipidemic agents. So depending upon the various metabolic problems, including if the patient has high parathyroid levels, we need to start him on drugs to reduce the parathyroid levels and control the metabolic parameters. And once the patient reaches the end stage of the kidney disease, in spite of all these measures, which eventually will happen, so at that stage, we offer the patient in end-stage renal disease, the modality of dialysis, which can either be the blood form of dialysis, that is hemodialysis, whereas in the purification happens through a machine and through a filter where all the urea, creatinine and toxins are removed. And usually the modality is thrice a week in end-stage renal disease patients, and some patients, selected patients with good urine output, whose function of the kidney is still around 15% intact, we can start with twice a week hemodialysis. So hemodialysis or peritoneal dialysis, which is the other modality, it is an abdominal form of dialytic therapy, whereas in the fluid is kept in the abdomen for around 4 hours. And the dwell time can change from 4 to 6 hours and even overnight, whereas in it is the characteristics of the peritoneal membrane via which the urea, creatinine, acids and all are drained from the peritoneal capillaries into the abdominal fluid, and then that is taken out or drained from the body. So it requires maybe 2, 3 or 4 dwells depending upon the characteristics of the person. And this type of modality is performed at home, usually in those patients who cannot go to for hemodialysis or who have a poor vascular access and where the fistula cannot be made. So an indication for dialysis in a chronic kidney disease stage 5 patient is when the kidney function is less than 15% and the patient presents with uremic symptoms. For example, nausea, vomiting, breathlessness, weakness, fluid retention, vomiting, which often goes and has blood in it if the person goes into uremic encephalopathy, or the patient has absolute oligonuria. So there are multiple indications, and refractory itching or uremic odor, which is the emanating smell, which is the bad foul odor from the body of the patient, can also be indications for dialysis, either hemodialysis or peritoneal dialysis. Now, the best and the most definitive form of treatment for such a patient who's in CKD stage 5 with uremic symptoms is kidney transplant. The modality involves taking the kidney from a donor and putting it into the body of a recipient after getting necessary tests of the donor as well as the recipient done, including the cross match, whereas when we see that the kidney is matched, both HLA and which is antibodies which are in the blood against the HLA of the donor, and ABO compatible or incompatible, whereas in a different blood group donor is donating to a recipient. So whether it is an ABO incompatible transplant or an highly sensitized HLA incompatible transplant, a battery of tests is done to see the health of the donor, the health of the recipient, and then the kidney is taken from the donor and put into the body of the recipient and anastomosed in a way that it functions for a long period of time, around 10, 15 years or so on. So the risks post-kidney transplant include risks of rejection of the kidney. If the person is not related or unrelated, for example, wife is there or a distant relative is there, there will obviously be chances of the donor kidney being regarded as a foreign body or a foreign object, and then antibodies forming against the kidney which has put into the body of the recipient and being rejected. Other than that, there are risks of infections, and the immunosuppressive medication that is generally given to a person during the kidney transplant is highly prone to diabetes, hypertension, high cholesterol levels, as well as infections post-transplant. So the person has to be in the follow-up of a nephrologist for a long period of time. According to the frequency should be determined by the nephrologist himself. And one has to make sure by getting recurrent tests done that the patient is okay and the kidney function of the patient is okay post-kidney transplant. So early diagnosis, awareness of symptoms and treatment of kidney disease is the difference between a person remaining healthy on medication for a long period of time or ending up on hemodialysis or requiring kidney transplant, or can even lead to mortality of the patient if not treated. The sad part in India and in developing countries is that because of the lack of awareness, the lack of the expertise and nephrologist opinion, the lack of resources, especially financial available, the patient is not diagnosed, not detected early, presents in an advanced stage, does not even have monetary means to get treated or get dialyzed or get a transplant done, and ends up dying. So we have to change this scenario, and we as both nephrologists and other primary healthcare physicians should work together in close proximity to treat this disease and to improve the outcome in the developing country where CKD is rising manifold as a epidemic, which is even more surprising since it's a non-communicable disease. Thank you.